Hi everyone, it's your friend Doris the Coder, and today we're going to talk about moderate sedation, also known as conscious sedation services. Now, based on the environment that you work in, you might not see the term conscious sedation, you might see moderate sedation. Particularly in the pediatric space, providers do not like the term conscious sedation because the kids are typically kind of not awake, but consciousness and awakeness are very different. Don't know, they don't like that. So we're going to talk about CPT codes 99151 to 99157. So first, let's ensure you understand what these codes are for and more so what they are not for. First, these are codes for moderate sedation, also might be referred to as conscious sedation. What that is not is anxiolysis, right? So just keeping the patient calm. Um, that is not what these codes are for. When you report a moderate sedation service, this is a patient who has a drug induced level of consciousness, right? So this patient might say a lot of things while they are under the control of a sedative, a moderate sedative, or a sedative that has taken them to a moderate level of consciousness that they will have no recollection of. It's actually funny. Some of the agents, this is like a natural effect of the agents. You could ask that person anything and they would answer you truthfully because they have no kind of control over and have zero recollection. So when a patient has moderate sedation, they are able to breathe on their own. So these patients do not need any kind of external or mechanical respiratory support. They can breathe on their own. They may give them a little oxygen or supplemental oxygen just because their breathing might be a little different. But this patient has full control of their respiratory effects, and again, they're able to respond. They won't remember it, but they're able to respond purposefully to what is going on. Some of the agents you'll see when they're doing moderate sedation now. Note here, just because you say that see this agent doesn't necessarily mean that it's moderate sedation. So I would caution you about that. But some of the agents you might see are Versed, fentanyl, midazolam, and everyone who knew nothing about medicine knows the one drug now called propofol. Why? This is a drug that was the cause of death with Michael Jackson, and I think it's case in point in propofol doing what it does if not properly administered and monitored. So when a patient has a moderate sedation service, the first thing the provider has to do is kind of get to know the patient. That provider needs to find out what medications that patient's on, what conditions they have, the kind of procedure that they're undergoing, the last time they ate, the general health status of the patient to undergo sedation. And that's kind of the eval. Now, when it comes to moderate sedation services, I want to make sure there are clear lines drawn here and there aren't any misunderstandings. Moderate sedation is not a type of anesthesia. You'll notice that these codes start 99, right? And anesthesia codes start 00. If this was an anesthesia service, they may have included it in the anesthesia section of the book. But moderate sedation is not an anesthesia service. In fact, as a practicing professional that deals a lot with anesthesia, I never report these services for anesthesiologists. When an anesthesiologist is involved, we use a type of service called monitored anesthesia care. That's not a level of sedation or along the spectrum of anesthesia or sedation, but it's simply a service by an anesthesiologist who has the ability to take the patient to all levels, up to the deepest level of sedation and maintain that if necessary for the procedure. Moderate sedation services are performed by all types of providers. So wherein I typically see the anesthesia codes just by anesthesiologists, you could see a moderate sedation service by a hospitalist, a surgeon, just any kind of specialty. There are state level requirements and some requirements one has to meet to administer some of these drugs. But largely, you can have this service be reported by any provider as opposed to what you see for anesthesia is largely just by anesthesiologists. We'll talk about the coding rules in a bit, but let me introduce you to these codes first, right? So you have two sets of codes when you code sedation. The first one, 99151 to 99153, and the second set is 99155 to 99157. Well, first thing is, why do we have two codes? First key question you want to ask yourself when you're coding sedation services on what code is appropriate, you need to ask yourself relative to the provider that's doing the sedation. What role does that provider play during that procedure? Put another way, is the provider who's doing the sedation, does that provider have responsibility for also doing the procedure that warrants the sedation? So I'll give you two scenarios here. One of the specialties I deal with is CVICU, right? So CVICU, this is the cardiovascular intensive care unit and critical care units. These providers do things like chest tubes, paracentesis, central lines, for example, lumbar punctures. When they are actually the providers who are doing those procedures. So they are the surgeons, the proceduralists, if you would. The patient they're doing the procedure on might need to have sedation, right? Moderate sedation. So the CVICU provider has two responsibilities. They've got to administer the sedation, and they also have to perform the procedure that the sedation requires. In that case, that's what my first set of code is for. That first set of code is for the provider who has dual responsibilities. I'll come back to this code in a second. In my second scenario, one of the lines I code for in the hospital is my hospitalist providers. Well, what very commonly happens is a child has to undergo a CT or an MRI or some kind of procedure. And because of that procedure, they need sedation. Well, radiologists, they don't do the sedation. So they will call a provider qualified and comfortable with performing sedation services to perform the sedation. That provider's role relative to the radiology procedure is only the sedation, because that provider who's doing the sedation does not do the radiology procedure. That's being done by the radiologist. And that is where your second set of codes come in. So when we dig into the description of the parent code, right? And when you look in CPT, I call it the parent code because it's a code. I mean, here it looks a lot better. It copies all the full definition, but the parent code has the complete descriptor at that code level, right? So this is for moderate sedation services provided by the same physician that's performing the diagnostic or therapeutic procedure or service that the sedation supports, right? So that's that first scenario I gave you, where my CVICU providers doing a chest tube or a paracentesis or a lumbar punctures or any of those procedures. They've got dual roles. Because there are dual roles, you have two hands and two eyes, and you've got to keep them focused on, like, you can only look at one thing at a time. Your hands can be one place at a time. So if you have a provider with dual roles, like the case in 99151, that provider has to have an independent observer. Case in point, Michael Jackson, right? You have to have an independent observer, because while you're focusing on getting the chest tube in the patient's chest and guiding that and making sure you don't hit any structures that you're not planning to hit or anything like that, someone has to keep their eyes on the patient's monitoring and their vital signs. This is why when we talk about intra-service time, it'll make more sense. This is why when you do the pre-sedation evaluation, you have to kind of do that interview to find out, like, what medical problems does a patient have. That also includes you getting some baseline parameters, because things like propofol can affect respiratory rate and heart rate, and those different kind of agents have different mechanisms of actions or things that they can throw off. We need to get some baselines for this patient to find out what's normal for this patient, because you and I can both have a heart rate taken, and my heart rate might be higher than yours, and that's normal for me, but it could be a cause of concern for you. So 99151 is going to require that someone keep their eyes on the patient's vital signs, right? From a documentation perspective, I recommend providers have the practitioner's name, so the nurse's name, for example. It might be an RN who monitors the vital signs, date, sign, credentials, all of that be part of the record. That is a requirement when the provider has dual roles. In the second scenario, that's what 99155's parent code is for. That's the same for 99155, 6, and 7 for this use. You, in this case, are like the radiologist that's being called to do that calls CVICU in order to do the sedation while radiology focuses on doing the sedation. Radiology focuses on doing the radiological procedure itself. In this case, that provider who's doing the sedation has only the responsibility for the sedation and nothing else. So you'll find that they don't make any mention of an independent observer because your eyes and focus is the monitoring with regard to that procedure. So those are your two code sets that you have when you're coding a moderate sedation service. Now, some key things you look for in order to arrive at the proper sedation service. That first part, you got to determine what's the role of the provider. Am I doing just the sedation, or am I doing the sedation and the monitoring? And when I say that, clearly you and I are different people, but in a practice, if it's your nurse practitioner, or even another one of your provider who's doing the monitoring or the observing to keep an eye on the patient's vital signs, you bill and you operate as one. So you want to use the first code set. So after you figure out first what the role is, the second part is you're going to say, how old is my patient? And you know what? Let me back up. I'm jumping the gun. I don't want to say the second is how old the patient. The second is time. How long was the procedure? Now, time is very tricky in CPT. You've got different guidance for time based on the code set that you deal with. You may have to meet the entire 15 minutes. You might have to pass the midpoint of it, or you could have a finite time that has to be a threshold that has to be satisfied before it's reportable. The latter is true in this case. So when you bill a sedation service where it says initial 15 minutes, you must, this is not one of these midpoint ones, you must perform a minimum of 10 minutes of intra-service time before the service is reportable with the sedation code. If it is less than 10 minutes, it is not a service that's reportable with these sedation codes. So time is the second part. So first role, then time. Third is age. How old is your patient? And this you could just get from the patient's chart. Is this patient 0 to 4 years old, or is this patient 5 years or older? I like to say it that way because sometimes I have with coders when they say, well, younger than 5, does that include 5? It's a little tricky for them. So I just tell them, listen, when I train on this, go ahead and write next to 99151 and 99153. Nope. Yep. 99151 and 99155. Write 0 to 4 years old. And then the next code says 5 or more. So that's just easier for you when you're coding and processing, so you don't make a mistake in the code. Now, once you get that 15 minutes of time, you actually have a graph on page 816 of your 2021 Professional CPT edition that covers the different time intervals. And where you go from those time intervals and how many units you can get. So after you get your first 15 minutes, you use 99153 with either age code. It doesn't matter. It can be used with 99151 or 99152. You have an add-on code for each additional 15 minutes of intra-service time. I like to because I work in pediatrics. So for my team, we have kind of a reference sheet for them that I kind of add things together and give them ranges, because it's not uncommon for us to have like 100 minutes of sedation or a certain number of minutes of sedation. And I want to make sure we don't lose any units. So I make like a little sheet for my team, a reference sheet for my team with the ranges, so they can just go right to it, get the number of units and keep it moving. That's recommended if you find yourself going over, because your CPT book actually stops you at 83 minutes. It says 83 minutes or longer and reminds you to add 99157. Well, at 83 minutes, you're good. You know it's 5 units, but what if it's 140 minutes? How do you know how many more to add? So it might be helpful for you to make a reference for yourself like that, so you don't lose any revenue. You'll find that the second set of code follows the same rules. We need to know the role of the provider, we need to know the patient age, and we need to know the intra-service time on it. It doesn't say time, it says intra-service time. Providers sometimes believe that their time starts when they do, and that may be fine from a time clock payroll perspective, but it's not the coding intention of these codes. This is intra-service time, and intra-service time does not start until the sedative is administered. So one of the things I look for when I audit is I look at the time the agent was administered, and I make sure the provider hasn't over-reported their time because of that. The agent that's administered should absolutely be documented. The time the agent is administered should absolutely be documented. So it's really an easy metric. Um, so those are the three things you want to look for to decide when you have your codes what the proper code is and where you should be reporting that. That also covers your coding rules. Um, Remember your threshold as well. You've got to get to the 10-minute point. Another thing that's required, every sedation record should include the type of sedation the provider performed. Now, these are moderate sedation codes, so if it's less or more, you don't get to report that. These are not deep sedation codes. These are not minimal sedation codes. These are not codes for anxiolysis. If you fall in any one of those, these codes would not be reportable and appropriate for your provider. So make sure you meet that. Now, I want to speak a little bit about this when we talk about moderate sedation, because yes, I just said the provider should document the type of sedation, and I'll absolutely stand by that. However, there's kind of a curveball I'm going to give you, and that is if a provider says a service is moderate sedation, and I tell you this because I've had providers who've done this, they've said it's a moderate sedation service. You've got to ensure that the patient has control of their airway, because a patient who's sedated to a moderate level has control of their airway. They are able to breathe on their own. Even if they need a little supplemental oxygen, they're still able to breathe on their own. If this patient has a tracheostomy, if they have a trach or they're intubated, a mechanical airway, that patient doesn't have control of their airway and they are not a moderate sedation patient. Some providers believe that because they didn't put the airway, or the patient had the airway before they even came in for the procedure, that they're only billing moderate sedation, that it's a moderate sedation service. That is not the AMA's definition, and that's not their interpretation. Another important tip about these codes: notice that I said it's the role regarding the procedure. So whether the provider is doing the procedure and the sedation or just doing the sedation, the procedure reports, a procedure is in both of those scenarios. So these codes are only when it's related to a procedure. Working in critical care medicine, it is not uncommon for us to see patients who are medically sedated. These codes are not the codes you use for that. If a patient is medically sedated, they are ill enough to require that they are sedated so their body can kind of heal and the providers can kind of get plans together, right? That's not what these codes are for. These codes are just for when procedures are being performed, which is why I think sometimes, even though, yes, the providers have to document the level of sedation as a coder, you need to make sure that that patient has control of their airway. Because if you see that, like, yeah, they were in the CVICU and they're intubated and they're now having, an ECMO cannula removed, right? And the provider says moderate sedation, even though the provider said moderate sedation, it doesn't fit that definition. So your provider may need some education with regard to what that means in the level and continuum of sedation. But some providers think because they didn't do the airway and they didn't do anything deeper from a sedation standpoint, it's their intention that it's a moderate level of sedation. The AMA has actually clarified that that is actually not the case. When you do sedation services as well, you should have the ASA class or physical status of the patient documented within your record. That's absolutely a requirement. And these records, whatever records you look at, I see some moderate sedation records and I'm like, there's no evidence that you did continuous monitoring. Now, I'm sure, gosh, I hope so, but you probably would have thought that with Michael Jackson as well, right? That there was some continuous sedation because of the agent being given, even though it wasn't for a procedure. That's just kind of the case. In that case, you should have continuous monitoring, but there are some guidelines. For example, the ASA, the AAP published a really comprehensive article that I think is a best practice. You should have documentation that you have intervals monitored, right? So just simply saying, yeah, I monitored and doing a statement at the end and not having evidence of that is not something I recommend. Even though I would hope a provider wouldn't give a patient this kind of agent and leave them. So continuous monitoring is required, but you do want to ensure you have documented intervals of every 5 and or 10 minutes. I've seen different guidance and I can't remember where the 10 minutes came from, so don't quote me exactly on that, but I definitely saw the 5. That's a really good best practice, right? So there's no coding rule that I can point to that says that, but when you look at best practices and when they say how things should be done and the whys, I think it's good to give the provider some kind of guide to use that. So we've talked about sedation. I've told you what it is, what the codes are, some of the agents you might see, although you don't want to use that exclusively as a definitive to code the codes. You want to have the other guidelines we spoke about also, coding rules, documentation tips, and some unknowns of sedation. So with that, I will close this video. And you know what I say, like it if you do, share, subscribe, so you know when I post. I do that as often as I can. And until then, I will see you in the next video.